So now we're going to take a little break from embryonic development to talk about some of the technology surrounding human fertility, which is big business. The business of trying to get pregnant when you want to be and of trying to avoid pregnancy when you don't wish to be. We'll start with contraception. So the idea behind contraception is to prevent pregnancy. Of course, abstinence is extremely effective in that, but many people go looking for an alternative. There are barrier methods that are exactly what they sound like. They simply create a physical barrier that prevents the sperm from reaching the egg. There are oral contraceptives, or the pill. These are hormone-containing pills that women take. They are analogs of progesterone. And remember that progesterone, while it does support the lining of the uterus, it actually also prevents the release of follicle-stimulating hormone and luteinizing hormone. And those are the hormones that are key to triggering ovulation. Now, of course, if you're already pregnant, you don't wish to trigger ovulation. But if you're giving this hormone to somebody who's not pregnant and doesn't wish to be, then she also won't ovulate. So oral contraceptives work by preventing ovulation. There are what are called depot preparations. The common name is Depo-Provera, Norplant, Implanon. These are implanted devices. These are devices that are implanted into the mother that again release hormones that prevent ovulation. And then you have intrauterine devices which are implanted into the uterus. There are a couple different kinds, but the basic idea is they are also out there to prevent conception, either by releasing progesterone the way the oral contraceptive pills do, or sometimes their just very presence may prevent the sperm from getting to the egg or from the sperm and egg getting to where they need to be. There are other forms of contraception that are more targeted towards after you may have already had unprotected sex. So the first is RU486 or mifepristone. Okay. This is a very strong anti-progesterone. So this is a pill that would cause you to menstruate. So if you've already had unprotected sex, you're worried that you may have conceived. Even if an implanted embryo was already present, this will cause the uterine lining to slough off and will work within the first 8 weeks post your last menstrual period. So you can actually end a very early pregnancy or prevent one from implanting. As you might expect, this is a somewhat controversial method for a variety of reasons because it can end an ongoing pregnancy. Then there's Plan B, the morning, or otherwise known as the morning after pill. This is a synthetic hormone and one that would prevent either ovulation or fertilization. So this is not one that ends an ongoing pregnancy, but you have to take it very soon after you have unprotected sex, or it isn't going to work. Once ovulation or fertilization have already occurred, you can't prevent them. And then there are permanent methods of sterilization. Vasectomy and tubal ligation, classic options, both involve surgery to block the tubes, either in the case of vasectomy to block the tubes of the vas deferens that would allow sperm to pass out of the male body, or in females to block the fallopian tubes, which would allow the egg to pass into the uterus. These should be considered permanent, irreversible options, although on occasion people do attempt to have them reversed. It does not always restore their fertility. There's a newer option out there for women called Essure. It's a device that you implant into the fallopian tubes, which irritates the tubes, causing them to form scar tissue and ultimately blocking them. There have been some lawsuits about the safety of this particular method, but it's out there and it's an interesting option that doesn't require surgery. Now, on the flip side of contraception, we have infertility. And there are more people facing infertility than you might think. If you've never tried to become pregnant, it's something that you sort of fear. You don't want to be in many cases. You're trying to prevent it, and it's kind of a shock to some couples when they realize after all those years of prevention that it's actually a lot harder than they thought it was going to be. So 1 in 6 couples are infertile, and for up to 10% of them, they never figure out why. There are lots of different possible causes. There can be structural issues. So cystic fibrosis is a genetic condition, primarily a lung disease, but also causes absence of the vas deferens bilaterally in males. So they're missing them on both sides, which means they are physically incapable of getting sperm out of their body without help. So you can have a structural anatomic issue that makes you infertile. There are certainly hormonal issues. We talked about progesterone causing women that have insufficient levels of progesterone have trouble maintaining a pregnancy. Lots of infections can cause infertility. STDs in particular will do it. There are all kinds of conditions that women can have that will make it harder for them to get pregnant. There are chromosomal issues. So we didn't really talk about translocations, but this is the quick and dirty version. But you can actually have chromosomes that have traded pieces of each other with one another. And that makes it very difficult to go through meiosis properly because they can't pair in the way that they normally would. That makes it a lot harder to produce normal gametes. And for men with translocations, they produce lots and lots of abnormal sperm. They may have very low numbers of sperm or very low numbers of functional sperm. If you're interested in translocations, I love them. I'm happy to talk about them at length, but this isn't really the right class for it, so we can chat about it outside. And then there are some genetic changes that will cause infertility, including deletions on the Y chromosome that will make it impossible for men to create sperm. And what's shown here is just a sample test result showing what it would look like to have a test for these kinds of Y chromosome deletions, and what kinds of results you get back and what kinds of information you can learn from it. One of the interesting things is that based on the type of deletion you have, that can suggest an appropriate treatment. So some deletions can be treated. You, of course, can't fix the chromosome deletion, but you might be able to fix the infertility. For others, treatment is not so possible. This is just showing how is it that we examine sperm. So one of the classic things that's done in an infertility clinic is that men give a sperm sample that can be analyzed to determine whether or not their sperm is of good quality and likely to be functional. And trying to figure out what the cause of infertility is, they do look at both men and women. So for men, they look at a bunch of different factors with respect to sperm. The volume, how much semen is there. There's the quality of the semen that they can look at. How likely is it to interfere with fertility? They look at sperm count. That's a big one. How many sperm do they see per millimeter? And that's what's shown in the picture there, a grid that you can use to help you count sperm. They look at the shape of the sperm, how well they're swimming, the acidity of the semen. They look at a couple other levels, including a fructose level. Fructose is the sugar that sperm actually eat per se, but it helps to fuel them. And if you have abnormal levels of fructose, your sperm may not function well. What do you do if you have infertility? It's a lot easier to treat if you know what's causing it than if you don't. But there are options for folks even if you don't know what's causing it. There are some lifestyle modifications you can make. Sometimes something as simple as timed intercourse or a pair of loose or jockey shorts for men can make it easier to get pregnant. There's artificial insemination. Okay, so for example, a man with cystic fibrosis who is not able to ejaculate sperm might use sperm from somebody else that can be implanted into the woman, and that may be all it takes to get pregnant. Sometimes hormonal medications can help to increase ovulation potential or to reduce the risk for miscarriage. When you use hormonal medications to increase the chance that a woman will ovulate, you do run the risk of her ovulating multiple eggs and having multiple babies, and multiple births are always higher risk. And then we come to in vitro fertilization, where you collect eggs and sperm from the potential parents and allow them to fertilize in a dish, and then allow the embryos to grow usually to about the 8-cell stage, and then implant them into the mother's uterus and hope it takes. Very popular choice, although it's worth pointing out that if you have normal fertility, you will be less likely to get pregnant with IVF than if you just try it on your own, because while IVF might work well for somebody who has subnormal fertility, it's never as good as normal fertility. Something that can go along with IVF, pre-implantation genetic diagnosis and pre-implantation genetic screening. So that's what's shown in the top set of pictures, where you're actually selecting one cell from the 8-cell stage and testing it for a genetic condition you're worried the baby might have, which would then allow you to only put in embryos that don't have that genetic condition. A very powerful technique. And remember, when you're at the 8-cell stage, you're still in that all or nothing period. So even though you've taken out 1/8 of the cells of the embryo will recover. Another option is intracytoplasmic sperm injection. So for men whose sperm are not able to fertilize the egg for whatever reason, you can actually inject them directly into the egg. And then we sort of get to this idea of 3-parent babies, which we're going to circle back to. But this is a technology aimed at helping women with a particular type of genetic disorder to have healthy babies. So risks with infertility. Multiple birth is a big one. 37% of babies conceived with assisted reproductive technologies will be in sets of multiples versus the 2% general population risk. And we'll talk more about multiple births in later weeks, but they are much, much higher risk, particularly when you get up to triplets, quadruplets, and more. Some of these assisted reproductive technologies do actually increase the risk for birth defects as well. We don't entirely understand why. And then there are any number of risks to the mother, including high blood pressure, diabetes, bleeding, anemia. You can get ovarian cancer from excessive hormone use. There are risks. But for most couples, they would tell you that it is worth it. So this is Louise Brown. She was the first baby born following an IVF procedure. She was born back in 1978. And there have been millions of babies born following IVF since Louise was born. For most families, they would consider all of these risks to be worth it. And that brings us back to the idea of 3-parent babies, something that's current events in the news. And this is a technique used to help women with a particular kind of disease called mitochondrial disease. Mitochondria are the powerhouses of your cells, as I'm sure you know. They produce energy. And so diseases that affect them affect high energy tissues and muscles disproportionately. So you see effects in muscles, the heart and skeletal muscles, brain, eyes, areas that require a lot of energy. And mitochondrial diseases all tend to fit a particular profile. So they all tend to produce muscle tone issues, reflex issues. They may produce seizures. They may produce enlargement of certain organs and progressive loss of muscle function. So in this particular case, we're looking at a real-life family, and this is not a family from a clinic that I've worked in. This is a family that's made their story public. And the child in the picture is Matty Stepanek. He died when he was 14. Matty was the youngest of 4 children. His mother, Jenny, had 4 children with an ex-husband. The first 3 all died as young children before Matty was born and before anybody ever figured out why. After Matty was born, he was actually the healthiest of the 4, but he began to show signs of dysautonomic mitochondrial myopathy, with which he was ultimately diagnosed, a mitochondrial disease that Jenny herself was ultimately diagnosed with. And it was later concluded that that was the cause of death for the first 3 children. Now, mitochondrial diseases are really interesting because there are genes that regulate the mitochondria within the nucleus of the cell, but also within the mitochondria themselves. And if the genes that are causing the problem with mitochondrial function are within the mitochondria themselves, then they follow a mitochondrial inheritance pattern, which means that each mother that has the disease will pass it on to all of her children, because all of the mitochondria from that a child inherits come from the mother. Remember that the egg accumulates all the mitochondria. That's part of why you don't get 4 gametes out of oogenesis. You get 1, and all of the mitochondria, all of the cytoplasm is accumulated in the 1. Whereas sperm are streamlined with all that cytoplasm shunted off into the Sertoli cells, so the sperm do not actually contribute, well, theoretically, any mitochondria, although it does seem like perhaps they contribute a little. At any rate, with Jenny having this disease and having it caused by a mutation in her mitochondrial DNA, she would pass it on to all of her children. Now, And I should just point out, Matty Stepanek was actually a very, very bright child. He was an accomplished poet, a great deal of potential. And if you're curious and interested, you can get on the internet and find his poems and readings and things that he wrote and things that his mother has written after his death. Okay, so that brings us to another complication of mitochondrial disease that's going to be important to understanding this issue of three-parent babies, and that's the idea of heteroplasmy. The idea that some of the mitochondria within your cells might have a mutation that affects their function, but others do not. And that as women reproduce, over time, you start to see changes in the proportion of normal to abnormal mitochondria. So what you can see is that as cells divide, of course, the mitochondria go randomly to one daughter cell or the other, and you may end up with a daughter cell that has more abnormal mitochondria than the mother did. And so when you have multiple possible distributions of normal and abnormal mitochondria, you can see different severities of the disease. Okay, and that's what's shown here. But over time, once a woman, for example, has become symptomatic, presumably the proportion of abnormal mitochondria in her cells is increased to the point where all of her children will also inherit abnormal mitochondria, and there will be a tendency for there to be more and more abnormals until you get to the point where a child actually has such severe disease that it causes early death, which is what was happening in Jenny and Maddie's family. So these are severe diseases. Because this is passed on within the mitochondria themselves, something like PGD isn't going to work. We can't test embryos and find the unaffected ones because there are no unaffected ones. So what are the options for these families? Well, they can continue to conceive children naturally, and in which case all of their children will be affected to some degree, although it will vary and some may be more mildly affected. You can use an egg donor who's unrelated to the mother and consequently will not have the same mitochondrial disease. You can look at donated embryos, embryos that were part of somebody else's fertility treatment that they aren't going to use, that are unrelated to either of the two parents in question, so the woman with the mitochondrial disease or her partner. Of course, you can look at adoption. Adopting children has its own challenges, as it can be very expensive, emotionally draining, very time-consuming, but it's an option. And of course, some folks choose to have children. And while I will say I do have children myself and they're lovely and wonderful, there are many, many things that are just so much easier if you don't have them. And there are families that do sort of face these obstacles and decide that they don't want to go forward with having children. And that's an option too. Now, this week's class discussion is going to focus on this particular issue, the idea of three-parent babies, a treatment proposed for families where women have a mitochondrial disorder that poses a significant risk to their children. Although there are two different methods that have been sort of talked about, the basic idea is the same, to separate the nuclear DNA from the mother from her mitochondria. And so ensuring that she has a biological child that doesn't have the mitochondrial disease. So you can either do that by using a donor embryo and implanting the parent's pronuclei from the egg and the sperm into the donor embryo and then allowing it to develop. Or you can separate the nucleus from the mother's egg and implant it into a donor's egg and then allow it to be fertilized by the presumptive father's sperm and then to develop from there. Now, this technique has been used just a couple times thus far. Children have been born. They are, thus far, as best we know, healthy. This has not been done in the US yet, so data is limited. But we are seeing that those children do contain some abnormal mitochondria, although certainly not in large proportions. And it's interesting because some newer data is suggesting that the mitochondria may actually evolve with the nuclear DNA. And so it's possible you could have a mismatch between mitochondria that were poorly evolved to the nuclear DNA if you use this three-parent baby technique, and that you may get different interactions. There's also the possibility that the abnormal mitochondria might outcompete the normal ones, and therefore increase in proportion in these babies, and you might still end up with sick babies. So there's a lot left to learn. There are some assigned readings to go along with this discussion on the course website, and of course, please do explore and find additional resources of your own. This is what we'll be discussing in class this week in our online discussion. Is this an ethical technique to use? Is it something that we're ready to use in humans?